Hello. So today we're going to discuss some of the clinical indications for uh, performing ERG testing with the Redival device and discuss one of the cases that we saw in our clinic that demonstrates usefulness across multiple pathologies. My name is Dr. Bradley Grant. I am one of the optometrists and part of the ownership of two clinics, Midstate Eye Partners and Eye Wisconsin in Illinois and Wisconsin. We have incorporated the Redival device across all five of our locations, and we've been running these tests since June of 2023. Really made the decision as an organization to incorporate the Redival technology, first and foremost, just to elevate the level of care that we provide at our clinics. We highly believe in the diagnostic capabilities of the test. We do see quite a bit of pathology at our offices, and so we really enjoy having a test that is an objective functional assessment. Most of the testing that we do is subjective, and it leaves room for patient error or poor data. So the objective nature of the test really is what drew us in initially. And we'll discuss that in this particular case as we move forward. So um, my experience with ERG, like I said, we have had the technology in our office since June of 2023. Over that time, we have performed roughly 1,500 tests across five locations, and so you have a good database of information to dive into. What we did at our clinics is basically created protocols where we ran the test first on every diabetic patient. We do this whether they have diabetic retinopathy or just newly diagnosed diabetes for a baseline exam. We do highly believe that this is the new standard of care in diabetic eye exams, and so we do perform this test on anyone who has diabetes at least annually, and sometimes more often than that, depending upon the level of severity or presence of retinopathy. We also perform this test, the Flickr 16 protocol, on all macular pathologies, including different forms of age-related macular degeneration or drusen. We do routinely perform the PHNR protocol on optic nerve pathologies, those being optic atrophy, glaucomatous optic atrophy, different optic nerve entities that you might encounter. And what we really love about this test is its portability. Again, in our clinics, we do see a relatively high volume of patients. And so we're always looking for technology that doesn't create a slowing down point in the clinic. As you know, many of our instruments take up a full workup testing room. If you're running a visual field on someone, you can't do another test in the same room at the same time on a different patient. And so the portability of the tests, where it can be, in our case, performed in the exam room after the workup is performed, was highly valuable to us because we could integrate it into a busy clinic schedule without slowing down our general flow. So we'll dive right into this case. This is an individual that we have seen since 2019. Most of her significant ocular history occurred before that, but she's a 70-year-old white female. Family history, diabetes, hypertension, cancer, pretty common in terms of family history. Patient history, positive for multiple sclerosis, thyroid dysfunction, and high cholesterol. Interestingly, with her multiple sclerosis, she had been told by her neurologist that she no longer needed to be seen routinely by neurology. Now, she had an episode of optic neuritis, which we'll jump over to ocular history, had an episode of optic neuritis in her left eye greater than 10 years ago. Her best corrected vision in the eye was hand motion, yet she was only being monitored medically by primary care and us. And so she was no longer seeing neurology, no longer actively being treated for MS. Did have a family history of legal blindness, was somewhat poorly defined, but did mention glaucoma, cataracts, and degenerative disorders of the macula. So our assumption is that likely from some form of macular degeneration. When we first saw this individual in 2019, again, we did not run a baseline ERG until 2023, and that's when we first acquired the technology. So some of the testing that we did, again, we talked about acuities. Right eye acuity was 20/20, and left eye acuity was hand motion. You can see the images of the fundus here, right eye, left eye. Main thing that you'll notice right off the bat is the asymmetry of the optic nerves in terms of pallor. Again, there is a little bit of cupping in both eyes. Right eye has a little bit of a superior notch, but the highest concern that we had was the pallor in the left eye. Additionally, you can see that there is drusen greater in the left eye than in the right eye, and not the easiest to tell on this photograph, but there is also an epiretinal membrane, which you'll be able to see on the OCT in that left eye as well. The right eye does have a little bit of cupping, as we mentioned, as well as some scattered drusen. So especially in an individual who is 20/20 in their good eye and hand motion in their left eye, we're obviously concerned about the left eye, but we also want to protect the right eye as much as possible. Visual field testing, right eye really unremarkable. VFI at 100%. Left eye, we really were never able to get an accurate visual field. Again, with hand motion vision, she routinely would fail the visual field testing based on high fixation losses. Best VFI we had seen was 21%. Again, this greatly underscores the value in an objective functional test. The only functional test we had previously for this patient was a visual field, which was subjective, and we were really not able to gather useful information given the high fixation losses. So let's talk a little bit about the optic neuritis history in this patient. Again, as we mentioned, she was not actively being seen by neurology. That concerned us given what the optic neuritis treatment trial tells us about the likelihood of recurrence in optic neuritis in patients with a history of diagnosis of multiple sclerosis. Actually, the recurrence rate per the ONTT, which is a landmark study performed decades ago, but the results have withstood the test of time. 5-year recurrence rate was roughly 30%. Saw a couple references, one 28%, one 32, and the 10-year recurrence rate was at 35%, both based on the ONTT. So the take home is that when you have a patient who has optic neuritis and a systemic diagnosis of multiple sclerosis, we need to be watching those individuals very closely because the likelihood of having optic neuritis again is incredibly high. All right, so we'll dive back into this particular patient. These are the OCT findings. First thing you'll notice is that the fixation in the left eye is poor. And so we're doing a macular OCT based on the history of drusen. Again, right eye, you can see just a few blips in terms of that back line and a couple drusen. Left eye, poor fixation. You can see as you look in the upper right there that there is a fairly significant epiretinal membrane, but again, with her inability to focus on a target straight ahead, given the poor vision in that eye, this is the best we could get in terms of the OCT. So we decided to run an ERG in this patient. One is a baseline for a couple different reasons. One, they have history of optic neuritis, and so we are wanting to have a functional assessment of the retina in comparison right eye and left eye so that we can long-term watch for possibly early recurrence. They also have drusen, so they have a macular pathology, which again, right eye we're wanting to be ultra protective of, and so we want to know functional assessment of right eye versus left eye in that macular area, so that way we can have educated conversations with this individual about when the treatment may need to take a different course if things do get worse. So we'll show you the ERG. We did the Flickr 16 protocol on this individual. You can see right eye here in terms of, we're looking at the bottom waveform. The amplitude is all within normal limits in terms of the height and the strength of the amplitude, and the latency is fine as well. Again, this eye from a pathology standpoint has some early cupping. I would call this just a suspect optic nerve, and then some scattered drusen, but again, the functional assessment of this eye, perfect amplitude, perfect latency, everything in the right eye thankfully looks good. On the left eye, especially as you look at these tests, just as a whole, right versus left, you can see right off the bat that the amplitude in terms of the strength of those waveforms is quite a bit reduced. Actually, as you look at the red and the green, the amplitude is just barely falling within the normal range, but when you take that in comparison to the right eye, you can tell that it's definitely reduced based on the level of response in microvolts there. The latency is certainly reduced. That actually falls outside of normal range. And so in this individual, we are seeing both a reduction in the amplitude as well as an increase in the implicit time, indicating certain retinal pathology. So what are we going to do with this patient? We are going to monitor this individual every 6 months, both from the standpoint of the existing drusen and the history of optic neuritis. We did recommend AREDS supplementation vitamins on a daily basis. We repeat the visual field tests and the OCT imaging every 6 months. Again, we are highly concerned about any visual field defects and subjective functional testing decreasing based on the right eye. And we're going to repeat the ERG every 6 months as well. Again, now that we have a firm baseline in terms of the implicit time and amplitude, right eye and left eye, it's going to really give us great value in determining any compromise, further damage to the left eye or compromise to the right eye. So why do we firmly believe in ERG in an individual case like this? So one, it gives a good functional assessment, much more valuable information than just what is your acuity in the good eye, what is your acuity in the bad eye, and that's really what the patient was focused on. It gives us functional assessment for a patient that is no longer seeing a specialist, no longer seeing neurology, and so we have essentially become her specialty care. We did advise her that we felt like she should be continuing to see neurology, but if she does not, at least we are in some ways stepping into that void. It does provide progression analysis for a functionally monocular patient. Again, we've touched on this multiple times, wanting to highly protect the right eye and watch for any early signs of pathology that might require different treatment than we already are advising. And I think lastly and most importantly, I do believe that this increases patient compliance, whether that be with current regimen of ARED supplementation, appropriate follow-up care. The way that the ReadyVal device can lay out the testing in a digestible form for clinicians and patients really helps with patient conversations. And I truly believe that this increases patient compliance. And we all know that when patient compliance is increased, then we have better outcomes. And whether that's better outcomes with current treatment regimen, current follow-up regimen, or even sometimes showing up for follow-ups with specialty care that we recommend. Again, we have recommended that this individual get back in routine follow-ups with neurology, and I believe we've increased the likelihood of her doing that with the testing we're able to perform. So thank you for your time and for diving into this case with me. Have a great day.